So, continuation of the ST segment, we have the 67-year male patient presented to the ENT department at around 2 p.m. with pain in the left ear since morning. Troponins are like positive. The routine ECG shown is as follows. What is the treatment that you will give to this patient? The options are streptokinase, the primary PCI, anticoagulants, permanent pacemaker insertion. Okay. Now, if you just zoom this ECG and observe very clearly, what is the abnormality that you are able to identify or notice? The abnormality that you are able to identify or notice is in the leads V2, V3, and as well as V4. You don't have significant ST segment elevation, but you are having the T wave inversions are there. Okay, T wave inversions are there. And in this V4, you are having ST segment depression, and you're also having the T wave inversion as well. But this patient, if you observe, the troponins, they are positive. So what is this suggestive of? This is suggestive of non-ST elevation MI. Right? This is suggestive of non-ST elevation MI. So in case of non-ST elevation MI, what is the ideal treatment? Do we do thrombolytic therapy? No. Thrombolytic therapy is not indicated in case of non-ST elevation MI. Only in patients with ST elevation MI we do thrombolysis. Then primary PCI should not be done in patients with non-ST elevation MI. That is also the option. That is, primary PCI is also the option for your ST elevation MI. And your permanent pacemaker insertion, it is the option of the treatment for patients with the complete heart block, not in cases of non-ST elevation MI. So the answer in this patient is the anticoagulant should be given. And what are the anticoagulants that we give in case of non-ST elevation MI is either we give low molecular weight heparin, right? Or the another important alternative is the fondaparinux. Right, the other important alternative is fondaparinux. So this will be the treatment options for the non-ST elevation MI. Along with the anticoagulant therapy, you also need to add DAPT, that is dual antiplatelet therapy, and along with that, you also need to add the statins as a treatment. So DAPT, it stands for your aspirin, which one of the antiplatelet drug, along with that clopidogrel. So aspirin and clopidogrel, both of them are the antiplatelets. So that is what is nothing but your DAPT, which is nothing but dual antiplatelet therapy. Okay. So this ECG is suggestive of non-ST elevation MI of the anterior wall. Okay. Now, after having discussed about this, now let me show you another ECG with ST segment elevation. So I have shown you the ECG of anterior wall MI, lateral wall MI, non-ST elevation MI, inferior wall MI. Okay, but anyways, and let me show you one more ECG with the STT changes in the inferior wall itself. So you are having ST segment elevation in lead 2, lead 3, and as well as the AVF. But if you very closely observe here, this is the ST segment elevation in the inferior leads. What is the question that can be asked for you is, a patient has come with chest pain. The ECG is as follows. What is the vessel that is being blocked in this patient? Okay, the vessel that is being blocked in this patient is the right coronary artery, because the inferior wall, if there is an inferior wall MI, the inferior wall is supplied by your right coronary artery, and it is your right coronary artery blockade that will be responsible for this inferior wall MI, right? Next, one more ECG I'll show you. A 58-year male presented with epigastric discomfort. By seeing the ECG, patient was taken for emergency PCI. Coronary angiogram shows the lesion in the left anterior descending artery, left circumflex artery, right coronary artery, left main coronary artery. Now, you zoom the ECG and see the abnormalities. You are having the ST segment elevation in 2, 3, and as well as the AVF. And along with that, you are having the ST segment depression, where in lead V1, V2, and as well as V3, you are having ST segment depression. Along with ST segment depression in V1, V2, V3, if you take the R by S ratio, R by S ratio, it is like more than 1 in V2. If you take V2, the R by S ratio is almost more than 1. So this ECG is suggestive of the inferior wall MI because you are having ST segment elevation in 2-3 AVF, and along with that you are having the ST segment depression in lead V1, V2, V3, and R by S ratio is like more than 1. This is suggestive of the posterior wall MI. This is suggestive of the posterior wall MI. So inferior wall and as well as posterior wall, both of them, they are supplied by the right coronary artery, right? Both of them, they are supplied by right coronary artery. Okay, so this is about the ECG suggestive of the posterior wall MI. And whenever you see the ECG changes suggestive of the posterior wall MI, what is that you need to do is you need to replace V1, V2, V3 to the place of V4, V5, V6, and your V4, V5 and as well as V6, that has to be replaced to V7, V8 and V9, and you need to repeat the ECG. So in the repeat ECG, in V7, V8, V9, if there is posterior wall MI, you will notice that there is ST segment elevation. Alright, so right, so this is the placement of your V7, V8, V9 if you are suspecting the posterior wall MI. Right, so you see this. This is the ECG with leads which have been placed as V7, V8 and as well as V9. And in V7 you are having ST segment elevation, V8 and as well as V9. So this is suggestive of your, right, this is suggestive of your posterior wall MI. Alright, next question. The expected complication in this patient is aortic regurgitation, complete heart block, atrial septal defect, atrial fibrillation. Let me just zoom this ECG and you just see the abnormalities. You're having ST segment elevation in 2, 3 and as well as the AVF. And you are also having ST segment elevation in the right sided leads, that is in lead V1 and as well as V2. So what is that you have to observe here and make out here is your ST segment elevation is much more in lead 3, right? ST segment elevation is more in lead 3 than compared to that of lead 2. That is one point. And the second important point is you are also having the ST segment elevation in lead V1, right? And even V2. So your V1 and as well as V2, they are considered as the right sided leads. So these ECG changes, whatever you are observing here, it is suggestive of your right ventricular MI. And in patients with right ventricular MI, which is the vessel that is being blocked? That is the right coronary artery is being blocked. So when the right coronary artery is being blocked, what will happen? The blood supply to the SA node and as well as AV node is shut down. Once the blood supply to your SA node and AV node is being shut down, that will result in the development of the complete heart block, right? So expected complication in this patient is the complete heart block, okay? Because it is the ECG suggestive of right ventricular MI. So when will you tell right ventricular MI, particularly not inferior wall MIs, if the ST segment elevation in lead 3 is more than compared to that of the ST segment elevation in lead 2, then we call it as right ventricular MI. Then whenever you are having the ECG changes suggestive of right ventricular MI, what is that you have to do is you have to place the leads on the right side rather than the left side. Let me show you that. Okay, so this is the placement of the leads on the right side. So V1R, V2R, V3, V4, V5 and as well as the V6R. With this, you need to repeat the ECG. So once you repeat the ECG, you will find that there is ST segment elevation in V4, V2, V3 and as well as V4 and even V2 and even V1. So V1 to V4, you are having the ST segment elevation if it is right ventricular MI and you have placed the leads on the right side. Okay, you have placed the leads on right side. Okay, so that is about how to identify the posterior wall MI and as well as the right ventricular MI. So you just, let me just summarize what are all the conditions where you have ST segment elevation, what we have discussed until now. One is in patients with hyperkalemia, electrolyte abnormalities. Second, you get that in patients with left bundle branch block, right? Then third, you have that in patients with ischemic heart disease, you have the ST segment elevation, right? Which is nothing but your anterior wall MI, then your inferior wall MI, right ventricular MI, lateral wall MI. And fourth, what we have discussed is benign early repolarization. So these are the four conditions we have discussed until now where you have the presence of ST segment elevation. Then, right, you see this. What is the drug of choice for the patient presented with chest pain? Clopidogrel, atorvastatin, aspirin, streptokinase. Okay, so let me just zoom this ECG and tell you let me tell you the diagnosis. The ECG shows the ST segment elevation in almost all the leads except in your AVR where you have the ST segment depression. But whereas you observe in all the leads, right, you observe in all the leads, you are able to find out that there is ST segment elevation. Okay, so, right, so there is ST segment elevation in all the leads except AVR where you have the ST segment depression. And along with the ST segment elevation, what are the other ECG changes that you are able to find out is the PR segment depression, right? You can see that the PR segment is depressed in almost all the leads except in your AVR. In AVR, you are having the PR segment elevation, okay? So, you are having PR segment depression in all the leads except in AVR, you will notice that there is PR segment elevation. So this ECG, it is suggestive of the acute pericarditis. And in cases of acute pericarditis, what will be the drug that you need to give? You need to give anti-inflammatory drug. That is, aspirin should be given. Okay, aspirin is the drug of choice in this particular clinical scenario. So, right, either you can give aspirin or you can give naproxen. And in refractory cases where the individual is not responding to your non-steroidal anti-inflammatory drugs, that is the point when we give steroids. Okay, so the answer here is the aspirin should be given. Next question. Vasospastic angina, the most commonly presents as, right? Okay, so this is option A, this is option B, and this is option C, and this is option D. Okay, the answer, first I'll tell you the answer and then I'll give you the explanation as well. The answer is B. Now why the answer is B, let me tell you. So if you take this vasospastic angina, this another name is, it is also called Prinzmetal angina. And these patients with Prinzmetal angina, they will have the ST segment elevation within the ECG. In fact, you take in other two types of angina, that is stable angina and unstable angina, you have ST segment depression. Only in case of Prinzmetal angina, you have the presence of ST segment elevation. And these patients, they will have transient coronary vasospasm. Right, transient coronary vasospasm. And it is only when there is transient coronary vasospasm, right, it is only when there is transient coronary vasospasm, the blood supply to the myocardium will be reduced and that will cause the ST segment elevation. But you have to understand that this transient coronary vasospasm, it is most common in the right coronary artery. Right, it is most common in the right coronary artery. So if the right coronary artery is affected, then you have the ST segment elevation in 2-3 AVF. Right, in 2-3 AVF you have ST segment elevation because right coronary artery is the one which is most commonly affected. Then what is the drug of choice in patients with the Prinzmetal angina? In Prinzmetal angina, the drug of choice will be nitroglycerin, and followed by the nitroglycerin, the next alternative drug will be your calcium channel blockers. Okay, and that too, the calcium channel blockers will also the one which will cause vasodilatation. So now if you observe all the ECGs, right, the ECG B shows you that there is ST segment elevation in lead 2, right, lead 2, lead 3, and as well as the AVF, right, 2, 3 and AVF, you are having the ST segment elevation. So this is suggestive of, right, this is suggestive of your vasospastic angina, which is also called variant angina, which is also called the Prinzmetal angina. All right, next. So after having discussed about the vasospastic angina having ST segment elevation, now let me show you one more clinical condition where you have the presence of ST segment elevation. 23-year male came for routine checkup. There is family history of sudden cardiac death in this particular patient. ECG is as follows. What is the diagnosis? Arrhythmogenic right ventricular dysplasia, Brugada syndrome, hypertrophic obstructive cardiomyopathy, the anterior wall MI. So, right, let me just zoom this ECG and show you like what is the abnormality. You take lead V1 and as well as even V2 and to certain extent even V3. You are having the ST segment elevation, right? And the ST segment elevation, whatever you are having in your V1, V2, V3, right? The shape of the ST segment elevation, we describe this as saddle shaped ST segment elevation, right? We describe this as the saddle shaped ST segment elevation. Okay, so saddle shaped ST segment elevation, and that too in V1, V2, V3, that is suggestive of the Brugada syndrome. And these patients with Brugada syndrome, you have abnormality in the sodium channels, and this particular abnormality is in the SCN5A, that is the sodium channel. And because of defect in this particular sodium channel SCN5A, these patients, they are at increased risk of VT or VF, right? And because of this VT or VF, they are at risk of the sudden cardiac death. And that is the reason why you just see here there is family history of sudden cardiac death, and this is the ECG of your Brugada syndrome. All right, then so right, so this particular Brugada, right, okay, we have two types of Brugada, type 1 and as well as type 2, but type 1 is like very common, and this is what is your classical, the saddle shaped ST segment elevation. Now what is the treatment of choice for this condition? Cardiac resynchronization therapy, implantable cardioverter defibrillator, left ventricular assist device, intra-aortic balloon pump. So like what is the ECG? The same ECG what I have just shown you previously. That is your saddle shaped ST segment elevation, which is suggestive of your Brugada syndrome. Now, what is the cause for sudden cardiac death in patients with the Brugada syndrome? We have discussed VT or VF. Now you need to ablate or you need to terminate that your VT or VF whenever there is development of VT or VF. For that, you need to place the individual on the ICD, that is implantable cardioverter defibrillator, that will abort the VT or VF whichever has occurred in patients with the Brugada syndrome. You take cardiac resynchronization therapy. It is a treatment option in patients with dilated cardiomyopathy who are refractory to medical management. Left ventricular assist device, this is acting as the bridge therapy, right? Bridge therapy between the medical management and cardiac transplantation. So these patients with the heart failure, refractory to medical management, planning for cardiac transplantation, if appropriate donor is not available, they need to wait. So in this particular waiting period between the medical management and cardiac transplantation, we usually place the individual on LVAD, that is left ventricular assist device. And intra-aortic balloon pump, it is a treatment option for cardiogenic shock. Okay, and this IABP, it is usually avoided in patients with aortic regurgitation, and it is also usually avoided in patients with the aortic dissection as well. So the answer in this question is the implantable cardioverter defibrillator, because this is the ECG suggestive of your Brugada syndrome, right? Next. Okay, so 63-year male had hypoxic ischemic encephalopathy. The word HIE stands for hypoxic ischemic encephalopathy. Now, as a part of the management for hypoxic ischemic encephalopathy, he was managed at 34 degrees centigrade. And routine ECG is as follows, right? What is the abnormality that you are observing? So the patient is being managed or monitored at the temperature of 34 degrees centigrade. Okay. So what is all that you're observing is you're observing the presence of the ST segment elevation. And along with the ST segment elevation, in V4, V5, V6, you can see a positive blip, right? A small blip is there in V4, V5, V6 exactly at the J point. And this is what is called as the J wave, right? Or this is also called as the Osborn wave. And you see that in patients with the hypothermia. In patients with hypothermia, you have the presence of the Osborn wave or J wave. And along with that, they also have the ST segment elevation is what I wanted to show you here. So now what are all the conditions where you have the presence of ST segment elevation? That is in patients with electrolyte abnormality, that is hyperkalemia, then left bundle branch block, benign early repolarization syndrome, then your ischemia or coronary artery disease, then the next important will be your Brugada syndrome, where these patients can have the sudden cardiac death. And the third important, the next important condition is acute pericarditis. You can have ST segment elevation. Hypothermia, you can have ST segment elevation. So these are all the conditions where you have the presence of ST segment elevation within the ECG. And the pattern or the dynamicity, like it completely changes from time to time. And very important, I have also showed you is like ventricular aneurysm. Even in patients with ventricular aneurysm, you have tomb-shaped ST segment elevation where you have sustained ST segment elevation. Now, after having discussed about the concept of, the where all you have ST segment elevation, now you need to be very much aware of the conditions where you have the presence of the ST segment depression.